Hey class, welcome to the podcast on CVA or cerebrovascular accident. So stroke or brain attack, as they're now being called, are caused by reduced cerebral blood flow, and that causes brain cells to die, which leads to functional disability. There are a few different kinds of strokes, ischemic or hemorrhagic strokes, and we're going to be talking about these a little bit more in a few minutes, but ischemic stroke results from an occluded artery that deprives blood flow to a certain part of the brain, similar to what we talked about with an MI. Hemorrhagic stroke is caused by a ruptured artery or an aneurysm, and that results in bleeding in or around the brain. So a brain attack is the term that's now used by the National Stroke Association to better describe a stroke. And any stroke is a medical emergency. They strike suddenly and they should be treated immediately because that way there's a better chance of preventing neurological deficits and permanent disability. So just a couple of statistics. Stroke is the fourth leading cause of death in the U.S. The high incidence has prompted the establishment of many primary stroke centers, and they're also really trying to improve public education. There are 4.7 million stroke survivors in the U.S., and 730,000 strokes happen every year. Of those, more than 150,000 people die every year from strokes, and 25% of strokes occur in people younger than age 65. And stroke is the leading cause of serious long-term disability in the United States. So this is a serious problem that hopefully will improve with education of both healthcare providers and the public. So let's talk about the different kinds of stroke or the pathophysiology behind strokes. So like we talked about, ischemic strokes are one type of cerebrovascular accident, and a hemorrhagic stroke is the other kind. There are a few different types of ischemic strokes that we're going to talk about, kind of precursors. But what I want you guys, a main thing that you really need to remember, an ischemic stroke is a blockage or an occlusion, and a hemorrhagic stroke is bleeding from a ruptured vessel. All right, so ischemic strokes, they can be thrombotic or from a thrombosis, embolic from an embolism, and then the two different kinds, well, not really kinds, but precursors to an ischemic stroke, kind of like angina with an MI, but ischemic strokes, a transient ischemic attack has the same pathophysiological mechanism as an ischemic stroke, but the symptoms go away. So this is a precursor or warning sign for a stroke, and it's a brief interruption of the cerebral blood flow. It can be from a vasospasm sometime, it can be from arterial hypertension. Sometimes the symptoms last a few minutes to 24 hours, but usually they resolve within 30 to 60 minutes. If someone has more than one TIA, they are at a very high risk of having an ischemic stroke with possible irreversible damage. Speaking of, the next thing we're going to talk about is a reversible ischemic neurological deficit, or RIND. And this is another precursor or warning sign for stroke. And again, it's caused by a brief interruption in blood flow to the brain, and it has the exact same causes as a TIA. The only difference between a RIND and a TIA is that the symptoms last longer than 24 hours, but less than a week. So this still is reversed, which is why it's reversible. It is longer than a TIA, but again, it can be reversible. So ischemia is caused by an occlusion of a cerebral artery, and ischemic strokes account for 80% of all CVAs. Hemorrhagic strokes, on the other hand, bleeding from a hemorrhagic stroke interferes with the normal metabolism of the brain, and this can be either from an aneurysm or an arteriovenous malformation that ruptures, and an arteriovenous malformation is also known as an AVM. So some symptoms of a TIA or RIND or a stroke, and we're going to talk about these in a little bit again, but these are just some very important symptoms that you want to look for. Blurred or double vision, blindness in one eye, aphasia, which is no speaking, slurred speech, dysarthria, weakness in either an arm, hand, or leg. If you notice that the person has ataxia or a disturbed gait, if they complain of any numbness in their face, arm, or hand, or if they get very dizzy. These can all be symptoms of a TIA, RIND, or CVA. So I just want to go over a couple more things with the different kinds of CVAs. So a thrombotic CVA, the thrombotic stroke, there is a cerebral thrombus or clot that is caught up in the narrowing of the artery by plaque, very similar to what we talked about with an MI. Again, plaque causes a clot formation which blocks the blood flow through the artery. A thrombotic CVA accounts for more than half of all strokes, and again, this is due to atherosclerosis in the blood vessels. It is the same mechanism as the coronary arteries, except this is in the cerebral artery. So the clots formed from the plaques rupture and interrupt blood flow. This usually develops gradually over years. And there are actually two common areas that this occurs in. The first is the bifurcation of the common carotid artery, and the second is the junction of the vertebral arteries with the basilar artery. So these are two really common places for thrombotic CVAs to occur. All right, so an embolic CVA means that the clot originated somewhere else. Okay, so an embolic blood clot was already circulating in the blood, and it is going to get stuck in a narrow passage and block blood flow. So it can get caught in an area that is narrowed because of atherosclerosis. It might get caught in an area that's just too narrow for it, or at a bifurcation or where the blood vessels split. So again, with embolic CVAs, the blood clot is already circulating in the blood. It gets stuck in a narrow passage and blocks the blood flow. What do you guys think is the most common source of a blood clot that goes to the brain? That is from the heart. So if the heart is throwing blood clots, atrial fibrillation is a really common cause of blood clots forming in the heart, and that is a major concern of people who have atrial fibrillation. This is why they are on Coumadin, to prevent clots from forming in their heart and getting pumped right into their brain and causing an embolic CVA. The middle cerebral artery is the most commonly affected. And when people have an embolic CVA, they occur very suddenly. And the conversion of an ischemic stroke to a hemorrhagic stroke can occur because the arterial vessel walls might be vulnerable to both ischemic damage from the blood supply, and the sudden stress from that can actually cause the vessel to rupture. So an embolic stroke can end up causing a hemorrhagic stroke as well, and that has pretty devastating consequences. So hemorrhagic strokes, sorry about that. Hemorrhagic strokes, hypertension will increase the pressure against the walls of the cerebral arteries, and this causes a dissection, or it causes them to start to expand. The vessel integrity is interrupted, and bleeding into the brain tissue or the space around the brain, either the ventricular areas, the ventricles, or the subarachnoid space, can be where this bleeding sometimes occurs. This is often seen with sudden dramatic blood pressure elevation. So, like I said, some causes of hemorrhagic strokes can be an aneurysm, an AVM, or hypertension, as we talked about. So some risk factors for stroke, there are modifiable and non-modifiable risk factors, and I also included some different pathological conditions. Modifiable risk factors are going to be some of the same ones that we talked about for atherosclerosis: smoking, dyslipidemia or high cholesterol, diet, obesity, sleep apnea, and physical inactivity, just like we talked about with coronary artery disease. Non-modifiable, again, are the same: family history, age, race, and gender. Some pathologic conditions that can lead to being at a high risk for stroke: coronary artery disease. If they have coronary artery disease, you would imagine that they're going to have atherosclerotic disease in other areas of their body as well. So even if they're not exhibiting symptoms, you can well imagine that they have at least some narrowing of their cerebral arteries. Diabetes, hypertension, dysrhythmias, especially AFib, like we just talked about, migraine headaches, hypercoagulability states, and these are significant disruptions in the normal coagulation process. And sickle cell disease can also cause an increased risk for a stroke. Risk factors are identified and addressed. And for patients who have had a stroke, it's really important to modify as many risk factors as they can to prevent another one from occurring. And I know we talk about smoking a lot, but I just wanted to bring this up too. Smoking can actually double the risk of someone having a stroke within their lifetime. So, strokes can cause such disability and even death. So, patient education regarding smoking is just so important in healthcare. All right, so what aspect of an individual's unhealthy diet is associated with an increased risk of stroke? Excess intake of simple carbs, salt, protein deficit, or malnutrition? The answer is an excess of salt intake, and the rationale behind that is that high sodium intake has been identified as a modifiable risk factor for stroke. The other ones are not directly linked to stroke. So some symptoms of strokes that we're going to talk about: general cognitive, motor, sensory, cranial nerve function, and aphasia. We're going to talk about these a little bit in depth each. So some general symptoms of the stroke. They are usually generally the same regardless of the cause of the stroke. They can be related to the specific area and amount of brain tissue that's involved. The most common symptoms are a change in level of consciousness, and this really depends on the extent of the increased intracranial pressure, or ICP. Headaches are a very common symptom of strokes. Some cognitive changes that we're going to talk about a little bit in depth in a minute would be trouble understanding language, trouble speaking. You might see some motor changes like impaired coordination. These are just still general. And some general sensory changes include numbness, decreased sensation on one side, weakness, paralysis, and visual changes. So some specific cognitive changes that you might see, again, change in level of consciousness. You might see that they have a denial of illness. They might have a spatial or proprioceptive dysfunction. You might notice that they seem to have an impaired memory. Their judgment doesn't seem right, or their problem solving or decision making abilities aren't quite where they were. If you notice that someone has spatial or proprioceptive dysfunction, impairment of memory or judgment, those are all indicative of a right-sided brain injury. And problem solving or decision-making abilities, those are related to left-sided brain injuries. A decreased ability to concentrate and attend to tasks might be another common symptom. Now moving on to motor, this is where you might see either hemiplegia or paralysis. Hemiparesis is weakness, and hemi just means one side. Flaccid paralysis is also called hypotonia, and spastic paralysis is hypertonia. Agnosia is another symptom, and that is the inability to use an object correctly. Apraxia is something else you might see, and that is the inability to carry out purposeful motor activity. Incontinence or retention of urine or stool might occur as well. So these might all be some motor problems that you notice. Some sensory issues. People can develop neglect syndrome where they completely ignore the side of their body that is affected. That's usually indicative of a right-sided stroke. Some other sensory issues might be vision. You might see dilation or constriction of one pupil. Visual fields might be affected. Amaurosis fugax is a brief episode of blindness in one eye, and this is caused by ophthalmic arterial issue, or sometimes the carotid artery. If that's blocked, you can see this issue. Hemianopsia is blindness in half of the usual visual field, and this can be caused by damage to the optic tract or occipital lobe. Homonymous hemianopsia is blindness in the same side on both eyes, and nystagmus, I'm sure you learned about in assessment class, and that is caused by brainstem or cerebellar damage. And nystagmus, if you haven't heard of it, is just an uncontrollable shaking of the eyes. Cranial nerve function interruption that you might see might be the inability to chew. That would be related to cranial nerve 10. The inability to swallow, and the inability to chew would be related to cranial nerve 5. Inability to swallow could be cranial nerves 9 or 10. Facial paralysis or paresis would be related to cranial nerve 7. The gag reflex, again related to cranial nerve 9. Impaired tongue movements would be related to cranial nerve 12. And please don't forget that patients who have dysphagia or difficulty swallowing are at a really high risk for aspiration pneumonia. So everyone that has been diagnosed with a stroke will have a speech therapy consult to evaluate their ability to swallow. The last one that we're going to talk about is aphasia, and the aphasia is difficulty speaking, right? Everybody remembers that. So there's a couple different kinds. There is expressive aphasia, so they're having a tough time speaking. Broca's or motor aphasia, difficulty speaking or writing, or receptive aphasia or understanding, which is Wernicke's or sensory. Difficulty, and this is difficulty understanding spoken or written words. Sometimes they might use made-up words. Their speech might be meaningless. Sometimes their speech might be mixed. They might have global issues. And we'll talk about this in class, but my great-grandmother had a stroke, and she could only say the word birdie, and she would just say birdie, 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 and think that she was having a complete conversation with you, but the word birdie was the only thing that was coming out. As you can see, this is a profound speech and language problem, and it's really frustrating for the person because they are not able to be understood like they once were. Okay, so this is just a quick review of a right-sided versus left-sided CVA. And don't forget that left side damage will equal right-sided body weakness, and right-sided damage will equal left-sided body weakness. I'll just give you a couple minutes to go over these. You can pause this and look at these. So a quick determination of someone having a stroke is essential because we need to act very quickly to try to prevent deficits that are irreversible. So again, numbness or weakness on one side, confusion, trouble speaking, trouble understanding, if someone has visual changes, loss of balance or coordination, if they complain of a severe headache, especially a severe headache and their blood pressure is high, you really need to treat that quickly to prevent them from having a stroke, and you need to assess them to make sure that they're not having a stroke. So sudden changes with any of this, you need to have a high suspicion of a stroke. And they're really trying to improve the knowledge of the public regarding this because rapid diagnosis and treatment is essential. Again, numbness or weakness, especially on one side, if someone has a change in level of consciousness, if they have vision issues in one or both eyes, if they have any difficulty walking or falls, or a headache with no other identifiable cause. You need to check this out. And like we were talking about, in order to improve public knowledge of brain attacks and strokes, they are going to this FAST acronym, so people act fast. So face, arms, speech, and time. So face, does their face look uneven? Even. Ask somebody to smile. It is the fastest way to see if their face is even or not. Does anybody remember the arm trick? Remember what the test is? I hope everybody that had me for assessment does. But that's called a pronator drift. So if they hold their arm down in front of them and close their eye and one arm drifts down, that's a sign of weakness. And that can be a sign of someone having a stroke. If their speech is not right, are they making strange sounds? Can they repeat things after you? If you notice any of these, time is essential. So, and as they have written here, every second brain cells die. So if as you're relating to the public, as soon as they notice these symptoms, they need to call 911 right away. As you guys become nurses, as soon as you notice these symptoms, you need to get the doc on the phone right away or initiate a rapid response team. You do not want to mess around with a stroke because, again, if you do, the issues can be irreversible. So this is just, we're going to buzz through the different lobes of the brain so you guys can kind of remember what is affected. Taking care of people with strokes, if you have just a really basic idea of the functions of each lobe, you'll be able to recognize what lobe might be affected by a stroke. So, and we'll talk about that, why that's important in a little bit when we're talking about diagnosis. So the temporal lobe, short-term memory, loudness of sounds, interprets meaning, and hearing and discrimination of auditory input or hearing. Parietal lobe has to do with skin sensation, sensory interpretation and discrimination, and orientation in space or proprioception. The occipital lobe is where a lot of vision occurs, so visual interpretation and discrimination, and the meaning of written words, and also the interpretation of vision all occur in the occipital lobe. The frontal lobe initiates motor function. That's also where judgment and reasoning occur, personality. Broca's speech center is located there, and long-term memory, and also the olfactory nerve, which is what? Yes, that is right, smelling. So diagnostic tests. EKGs can be done, chest x-rays are done, CBC, BMP, they do coag studies, CT or MRI, EEG, angiography, and carotid Doppler studies. If they are concerned that if you are concerned that your patient is having a stroke, the gold standard is that they have a CAT scan immediately. All right. Really quickly, CAT scan versus MRI. The primary purpose of a CAT scan is to identify a hemorrhagic stroke. So, if someone is having an ischemic stroke, almost every time their first CAT scan is going to be negative. And that is because the brain tissue has not died yet. It is just ischemic. So it will come up normal. So a lot of times when people would come into the emergency department with stroke symptoms, we would not even get them off the litter from the ambulance. We would take them right over to CAT scan. And if there was no evidence of any injury on their CAT scan, we knew that they were having an ischemic stroke. So we knew exactly how to treat it. Their CAT scan was normal, and based on their symptoms, we knew that they were having a stroke. So that's going to be a really important thing for you to recognize. A CAT scan is only going to show hemorrhagic stroke initially. Now, a CAT scan is often repeated after 24 hours, and at this point, some changes of ischemia, infarction, and cerebral edema around that area can be seen. The MRI can show edema, ischemia, and tissue necrosis earlier than a CAT scan, especially done in angiography, can reveal abnormal vessel structure. So sometimes they use a combination of these different diagnostic tests to determine the severity of a stroke. So medical management is really going to depend if it's ischemic or hemorrhagic. So ischemic strokes, we're going to talk about the medical management a little bit more in depth, but they thrombolysis with recombinant tissue plasminogen activator. I know that sounds like a mouthful, but basically what that means is the blood clot, the thrombus, is going to be dissolved and gotten rid of with different types of medication that are recombinant tissue plasminogen activators. Okay, so these meds will dissolve the blood clot. As you can imagine, there's a lot of risk with those, which we're going to talk about in a few minutes. A hemorrhagic stroke, on the other hand, measures are taken to lower the intracranial pressure, and a lot of times hemorrhagic strokes, if they're treatable at all, the person is going to need to have surgery. So treatment for ischemic strokes. Again, thrombolytic therapy is often, we try to implement that within 3 hours of the onset of symptoms. And it is imperative to know exactly when somebody's symptoms started, because otherwise they might not be able to treat them if they can't guarantee that they fall within this limited time window. Again, we need to protect the patient's airway, make sure they're oxygenated. We need to keep an eye on their blood pressure and manage that. We need to assess their heart rhythm and monitor them for arrhythmias, treat those as they arise, and give them meds as ordered. And also, it's going to be important that they receive this thrombolytic therapy and intra-arterial thrombolysis. So, thrombolytic agents. Anytime you see lysis, that means destruction. So it is destroying the thrombus or the blood clot, all right? So thrombolytic agents dissolve the blood clot or occlusion in hopes of reestablishing blood flow. TPA or RTPA are the ones that are most commonly used. At the facilities I worked at, we always used TPA, which is Retivase. Everyone refers to it as TPA. It's the only drug approved for the treatment of stroke, and your book says that it needs to be given within 3 hours of the first symptoms. We would actually, if they fell within a 6-hour window, we would usually give it in the hopes of getting rid of the occlusion and reestablishing blood flow. There is a specific and select criteria for eligibility, and it is so important. What do you think you're going to need to monitor your patient for if you're giving them a med that dissolves blood clots? You need to monitor them closely for bleeding, especially signs of intracerebral hemorrhage. Sometimes these meds can cause a bleed in the brain as well, or a bleed anywhere in the body. So it's very important to monitor these patients very carefully. One other side note, which a nursing intervention that we'll talk about in a little bit, anybody that receives a thrombolytic agent, they cannot have automatic blood pressure cuffs. You need to do a manual blood pressure on them whenever you need to get it, because they can develop severe hematomas and ecchymosis from the blood pressure cuff if it's the automatic one. They have catheter-directed therapy, and this is sometimes used if system-wide therapy isn't effective. For example, if you give a patient the thrombolytic agents through their IV and it's not working, sometimes they'll put a catheter in and try and thread it up to where the blockage is, and they will insert the medication directly into that area. This is also performed within 6 hours of the event. So they can use urokinase, adaplase, or RTAP RTPA or Retivase. And again, we would use urokinase sometimes or TPA, and those were both the most common ones that we used. Anticoagulants are going to be very important too to prevent other clots from forming. So patients are usually started on heparin right away. They might be started on Coumadin as well. This is actually a source of controversy right now, and they're really going back and forth on if they're giving somebody thrombolytics, do they start them on anticoagulants too, just because of they would be at such a huge risk for bleeding, and sometimes this can have worse effects than the effects of the stroke would be. So I'll be interested to see how this plays out in the next few years. Platelet aggregate inhibitors. We talked about these we talked about all of these with MI as well. But aspirin um, is usually, aspirin is given if thrombolytics are not given. And if thrombolytics are given, aspirin shouldn't be given to a patient within 24 hours of any thrombolytics. So they'll hold that until the patient's at least 24 hours out. Ticlid, Plavix, and Persantine are some common platelet aggregate inhibitors or antiplatelets that can be used. And according to the 2011 American Heart and American Stroke Association guidelines, um, prevention of stroke in patients with previous TIAs or stroke, the optimal treatment in patients with carotid artery stenosis and TIA include platelets, statins to decrease their cholesterol levels, and risk factor modification. So the combination of Plavix with aspirin is actually now discouraged based on studies that showed that they had an increased risk of bleeding. AFib, they've been looking at this as well, but they're recommending actually to use aspirin alone due to increased risk of bleeding. But the data hasn't really been clear about this, so a lot of times patients are still kept on a low dose baby aspirin, 81 milligrams a day, in addition to Plavix is what I've seen the most. You might still see Ticlid as well. But these are still used for patients with stroke or at a high risk for a stroke. Antihypertensives are going to be very important as well. We're not going to talk about them again right now because we've talked about them already with MIs. You've had them in 150 as well, so you should be pretty comfortable with antihypertensives. Moving on to the treatment of hemorrhagic strokes. We're going to look for, again, airway protection and oxygenation. A lot of times people that are having a hemorrhagic stroke are going to need to be intubated if they cannot protect their airway. Prevention and control of increased intracranial pressure is going to be essential. One way that we can do this is controlling their blood pressure, and also they need to have good body alignment. That means their head of the bed needs to be at an appropriate level. Just positioning them appropriately can have a really high effect on their intracranial pressure. So these simple nursing interventions can really affect patient outcomes. Nimodipine, Nimotop can prevent vasospasms. And if the bleed is significant, the patient might need to be on anti-seizure meds to prevent any seizure activity. Just for reference, if the bleed is less than 30 milliliters, the patient usually has a pretty good prognosis. That's not a lot, right? That's a medicine cup full of blood. If they have 60 milliliters or more blood in their brain, they have a very poor prognosis. And if you think about it, the brain has no room to expand. And that's why the amount that can affect their prognosis is so minimal. All right. So I just want to talk about increased intracranial pressure for a minute very quickly, or ICP. People are at most risk for an increased ICP resulting from edema, usually within the first 72 hours of a stroke after the initial onset. The first sign of an increased intracranial pressure is a decreased level of consciousness. So Intracranial pressure is the pressure inside the brain, and this changes constantly. Tissue, blood, and CSF, or cerebrospinal fluid, the volume has to become high, and the compensatory mechanisms are not enough, and that's when the ICP starts to elevate. Neurologic changes begin if the intracranial pressure is higher than 20 millimeters of mercury. Normal ICP, just so you know, is less than 10. We need to treat an ICP that is between 15 to 20. If it's higher than 20, it's considered high. Okay? Just so you know, I am not expecting you to memorize the normal levels of intracranial pressure. If you go into like a trauma neuro ICU or an ICU setting of different kinds, yes, you would need to know that. For our purposes right now, you do not need to memorize these specific intracranial pressure levels. What you do need to know is that intracranial pressure will go up with bleeding in the brain. And the first sign that you're going to see of an increased intracranial pressure is a decreased level of consciousness, and patients are at a very high risk after a bleed in the first 72 hours. Okay. Cerebral perfusion pressure is an important thing to know. Again, you are not going to have to memorize this right now. I just wanted to give you this information. The cerebral perfusion pressure is just the mean arterial blood pressure minus the intracranial pressure. That's how they figure it out. And again, homeostasis usually maintains this within a normal level. But as someone has a bleed in their brain, this causes a shift in their ICP, which is going to cause their cerebral perfusion pressure to have issues as well. So as the intracranial pressure increases, their cerebral perfusion pressure will go down. And what I want you to know about this is that an increased intracranial pressure can lead to brain herniation. And do you guys remember what brain herniation is? That is when the brain will actually herniate out of one of the orifices. For example, a herniation at the brainstem, the brain can start to actually herniate out of the foramen magnum, the big hole in the back of the head. And that is usually occurs, someone will die from that within a matter of minutes or hours. And it results in cellular death. So once somebody has a brain herniation, if you hear that that is a concern, things need to happen quickly or that person is probably going to die. So some signs of increased intracranial pressure, some late signs that you might see, severe hypertension, if they are very bradycardic, if their pulse pressures widen. What does that mean? That means if the systolic and diastolic pressures start to widen. For example, initially, if their blood pressure was 140 over 120, and as this issue progresses, their blood pressure might change to 190 over 80. All right, that's a widening pulse pressure. Some neurological assessments that you're going to see, again, an alteration in level of consciousness. Their pupils are going to be altered. A lot of times their pupils will become enlarged and unresponsive to light. They refer to these as blown pupils. If you hear someone saying that, that's what they mean. They will have a decreased motor response, and this is when you're going to see a positive Babinski reflex. And we'll talk about this in class. I want to make sure you guys are all comfortable with that. One other thing that you might see is a negative doll's eyes when you're looking at someone's pupils. And so I'm not sure if you guys talked about this in assessment. I think I actually did not talk about this one in assessment, but a positive doll's eyes finding is actually normal. And if it's negative, that's abnormal. So the way, and I'll show you guys this in class, but the way you assess for doll's eyes is that when when you turn someone's head to the side, their eyes should move in the opposite direction, and this is normal. If their eyes just stay fixed and do not move, that is abnormal, and that's a negative doll's eyes. And this assessment is sometimes done on people who are either unresponsive or comatose. So treatment of an increased intracranial pressure, if the ICP becomes elevated, something needs to be done about that. They will give osmotic diuretics, and osmotic diuretics will actually pull fluid from the brain. They will give the patient sedation or put them in a barbiturate coma. And the reason they do this is because it minimizes the pressure on the brain. So keeping the patient sedated and unstimulated will really minimize any pressure on the brain as much as they can. Corticosteroids are going to be important to decrease cerebral edema. They might put in a CSF drain just to help drain any excess fluid off the brain. And again, surgical intervention is going to be very important. They either need to evacuate the hematoma or bruise, which means they will remove it. If there's a tumor causing this, they will remove that or repair the ruptured vessel that is leaking into the brain and causing this to occur. So as a nurse, if you have a patient with increased intracranial pressure, you need to keep their head in line. They can only log roll and have no pillows. Any flexion or extension of the neck can increase the ICP. You really want to control the environment and really decrease any stimulation. So, you might have to limit family visits, turn off the TV, radio, close the door. You want to keep it quiet, really low key. You need to maintain the head of the bed at about 30 degrees, and that really can promote the venous return from the brain. Monitor their vital signs and hemodynamics. You want to maintain adequate cerebral perfusion. You need to monitor their vital signs very closely to make sure that their condition isn't changing. You really want to decrease suctioning and the use of restraints. And the reason that is because they can both cause an increased intracranial pressure. And again, as patients have an increased intracranial pressure, their brain cannot tolerate stimulation. This will further increase their ICP. So some surgical treatments that we're going to talk about is a carotid artery angioplasty with stenting. And this is very similar to the coronary angioplasty and stenting that we talked about with MI. As I said, this is becoming much more common, and it's much safer than it was. They have devices now that can catch clots as they break off, because that was a major concern previously, because, as the vessels become more narrow, any clots that break off can float down and block off other areas of the brain. So this is usually done in the cath lab as well, or interventional radiology. There is a lot less blood loss involved, and patients have a shorter hospital stay, sometimes even overnight. And the post-procedure care is the same as an endarterectomy, which we'll talk about in a couple minutes. So this is just a picture of a carotid artery angioplasty. You can see with the stent. And they are still at a high risk for a CVA if the plaque dislodges or if the blood flow is cut off too long. And sometimes this procedure they'll do to prevent strokes if they find that the person has a lot of atherosclerosis in their carotid arteries. And as a nurse, how would you assess that? You would either hear a bruit or feel a thrill over their carotid arteries, and that would be indicative of plaque buildup. So this would be a procedure that would be done to prevent a stroke from occurring. Again, they are still at a high risk for having a stroke if any of those pieces of the plaque dislodge or if the blood is cut off too long. So, post-procedure nursing care, the patients would need vital signs as well as neurostatus. Usually it's Q5 minutes for 15 minutes, then Q15 minutes for an hour, and then Q hour for 4 hours, that kind of thing, as long as they are progressing appropriately. You really need to monitor the patient for bleeding. If they develop a hematoma from their carotid artery, that can actually compress the trachea and they might exhibit difficulty breathing. The hypoglossal nerve can also be damaged during surgery, so it would be important to have your patient stick their tongue out and move it side to side just to make sure that that is intact. Surgical management, carotid endarterectomies. Um, so this is similar. They do an EI bypass. It's similar to a CABG. They can bypass the occluded area. Um, an endarterectomy, though, removes the plaque from the inner lining of the carotid artery. So they actually will go in, make a surgical incision. You can see in the picture there, remove the plaque. They'll just pull out the piece of plaque and then suture the artery closed. And they usually have good effect with this in the prevention of stroke, but it is a very risky procedure. Postoperatively, again, really good vital signs and neurological care. You're again going to want to assess the patient for hematoma. Again, difficulty breathing, you want to assess the hypoglossal nerve and make sure that the patient hasn't had any damage to that. Some contraindications for carotid endarterectomies. If they have a complete internal carotid obstruction, there is no benefit in treating chronic obstructions. If they have a previous stroke on the same side that had um, negative effects, the damage is already done, and the risk by doing this procedure can actually worsen the patient's symptoms. If the patient is just not a good surgical candidate from another health issue, either the surgeon, anesthesiologist, whoever says the patient is not a good surgical candidate, they will not do this procedure. So this is the extracranial intracranial bypass, and this is done. This is what I was talking about. That is similar to a CABG, but it's in the brain. Craniotomy is performed. They make a graft or bypass from the first artery to the second artery. There are two more common techniques. That's the superficial middle temporal lobe to the middle cerebral artery, or the occipital to posterior inferior cerebellar artery. This is actually very, as you can imagine, very risky surgery, and there is a really high risk of intracranial hemorrhage with this surgery. Um, so I've actually haven't seen this done before, but in my background, I would imagine that would be very uncommon for somebody to have this. Cerebral aneurysms, the surgical treatment for a cerebral aneurysm, there's a couple different ways that they can take care of this. The first is surgical clipping, and this is actually the most common treatment for an aneurysm, and it is direct surgical clipping. So what they'll do is, under general anesthesia, they make an opening into the skull. That's called a craniotomy, and the brain is retracted so that they can see where the aneurysm is, and a small clip is placed along the neck of the aneurysm, and that blocks the normal blood flow from actually going into the aneurysm. And that is the picture all the way to the left. All right, that is this picture up here. You can see that little clip right there will block blood from going into the aneurysm. The clip is made of titanium and remains on the artery permanently. The next one that we're going to talk about is an artery occlusion and bypass, and that is this middle picture right here. So if a surgical clipping isn't possible, or if the artery is really severely damaged, the surgeon might completely block or occlude the artery that has the aneurysm. The blood flow is bypassed around the occluded section of the artery by inserting a vessel graft. So they usually take a smaller artery from in the leg again, and they will use it to connect above and below the blocked area so that the blood bypasses that blocked area. The bypass can also be created by detaching a donor artery from its normal position on one end and redirecting it to inside the skull and connecting it above the blocked artery. And this procedure is called a superficial temporal artery to middle cerebral artery bypass. The last one that we're going to talk about, which is this picture over here, is endovascular coiling. And this is performed with angiography as well, in the radiology department, usually by a neurointerventionalist. Often, a patient will need to be under general anesthesia for this as well. So with this coiling procedure, a catheter is inserted into the artery in the groin, passed through the blood vessels to where the aneurysm is. The doctor guides the catheter through the bloodstream while watching under fluoroscopy, just like in the cath lab that we talked about. Through the catheter, the aneurysm is packed with material, either platinum coils or balloons, and that actually will prevent blood from going into the aneurysm. Since coiling is a relatively new procedure, follow-up angiograms are still performed to make sure that the aneurysm is still occluded and not growing. Okay, so let's talk about your job in the nursing process. So patients with a stroke, because a stroke affects all parts of the body, we really need to do a very good and thorough assessment. We need to look at their mental status, motor control, swallowing, hydration, fluid output, skin integrity, and their activity level. Improving their mobility and preventing joint deformities is going to be a very important part of our treatment of patient with a stroke. We want to make sure to position them correctly to prevent skin breakdown and contractures. Their hands, fingers, and shoulders need to be positioned carefully, and an exercise program is really important to promote ambulation. We're going to have to maintain pain management, and really, it's going to be so important for us to promote self-care. So involve the patient as quickly and in as much of their own care as they can. So we're going to talk about some specific things that we need to do. We're going to talk about swallowing, mobility, communication, double communication because it's so important. Just kidding, I'll only talk about it once. Sensory perception, unilateral neglect, coping, home care, health teaching, and healthcare resources. So swallowing, it's really important to assess somebody's ability to swallow after a stroke, like I said before. We need to observe them for any facial drooping, drooling, if they have a weak or hoarse voice. We need to check and make sure that their gag and cough reflex is intact. They need to be positioned to facilitate swallowing. They might need some dietary changes like a thickener. We need to keep an eye on their weight. When they are eating, we need to do this and we need to teach them to do this, but they will need to place food in the back of their mouth on the unaffected side to promote their swallowing. It's going to be important to avoid distraction while they're eating. Keep an eye on them for any fatigue. And again, like I told you guys before, anybody that has a stroke is going to get a speech therapy consult to assess their swallowing. Moving on to mobility and self-care. We need to perform active and passive range of motion, allow them to perform as much active range of motion as they can, but we need to help them with passive range of motion for as much as they need that as well. Physical therapy is going to be consulted on admission, and you will work out a plan with them. Again, this is going to be an interdisciplinary approach. Positioning and transferring are going to be very important. DVT prevention is going to be very important. Again, they already have a blood clot in their, well, if it's an ischemic stroke, they already have a blood clot. If it is a hemorrhagic stroke, they're still at risk for DVT because of this sudden immobility. And it's also going to be important that we help them in restoring their ADLs as quickly as we can, and again, allowing them to participate in much of their care as they can. Communication, it must be important since I wrote it twice. They will see a speech and language pathologist as soon as they can. You might need to be repetitive with directions for patients. You need to speak very slowly and clearly and give them time to understand and process what you're saying and what is going on. Encourage them to communicate as much as possible. Even if they have communication issues, try and give them time to communicate the best that they can. Reinforce their behavior positively, and you might need to repeat the names of objects. You might need to use gestures or pictures to communicate with them, but it's really important to develop this communication with them as soon as you can. Sensory perception. Frequent verbal and tactile cues are going to be really important. You need to make sure to approach a patient from their unaffected side, especially if their vision is affected. Place items in their field of vision so that they can see it. They might need to wear an eye patch if they have diplopia. Make sure that their environment is safe. That means they may need to be reoriented. They will need to establish a new routine. Present information to people in a very simple manner, and give them pictures of familiar objects to try and improve this their sensory perception. In order to prevent unilateral neglect, um, encourage the patient to use both sides of their body. Make sure that you wash both sides. Dress the affected side first, and have the patient turn their head to see so that they can see their entire field of vision. If they don't turn their head and cannot see their affected side of their body, that's when this unilateral neglect can occur. Some coping that you want to assist the patient with, provide information and emotional support, not only to the patient, but their family. And please don't forget, but depression and despair are really normal responses to a stroke. This can be a completely life-altering event. So it's really important to provide emotional support. And it's really common for people to act out emotionally after a stroke. Not only are they going through all this, but if they had a frontal stroke, their ability to cope and their behavior might be affected as well. Some home care issues to look out for. Patients are going to need assistive and adaptive equipment. It's going to be very important that their home safety is assessed. A lot of times patients will have physical and occupational therapy involved in their home care, and they need to have their appointments arranged before their discharge. Their rehabilitation, speech, and any future diagnostic tests, at least the initial ones. Some health teaching that's going to be important is the medication schedule that they're on, as well as information about the medications, ambulation or transfer, how to do that. Again, depression is going to be really important. With it, usually it starts to improve after about 3 months, but it's a really rough time period, especially those first 3 months after a stroke. And the family needs to be involved in all of this as well. Some really good healthcare resources for you to share with your patient about would be the American Heart Association, the National Stroke Association, and the American Stroke Association. So some nursing diagnoses that we're going to talk about really quickly that are going to be important for patients that are having or had a stroke. Ineffective tissue perfusion, cerebral tissue perfusion, is going to be your top priority when a patient presents with CVA symptoms. You're going to look out for impaired swallowing, impaired physical mobility. They're probably going to have a self-care deficit. They might have impaired verbal communication. There's a good chance that they have urinary or bowel incontinence. They might have disturbed sensory perception, and again, they might have unilateral neglect, which we talked about. Okay, so an NCLEX question for you guys. The nurse knows that which of the following signs and symptoms is considered the earliest indication of an increased intracranial pressure. The answer is lethargy, all right, a decreased level of consciousness. So some goals for stroke rehabilitation. You really want to improve your patient's mobility. You want to avoid them having any shoulder pain. Achievement of self-care. You want to relieve sensory and perceptual deprivation. And a really important one, too, is going to be the prevention of aspiration. Some other ones promote continence of bowel and bladder. You want to improve their thought process and communication, maintain their skin integrity, restore family functioning and sexual function, and prevent any complications from occurring if at all possible. So here's just a quick cartoon about a poor nurse trying to assess a patient. I know it's nerdy, sorry. All right, last thing. In order to prevent the development of shoulder pain during recovery from a stroke, the nurse should avoid contact with the patient's weak arm whenever possible, avoid taking the patient's blood pressure on the affected arm, support the patient's weak arm on a pillow or table, let the patient's weak arm hang loose whenever possible. The answer is support the patient's weak arm on a pillow or table. And the rationale behind this is that many shoulder problems can be prevented by proper patient movement and positioning. So the flaccid arm should be positioned on a table or with pillows while the patient is seated. If you let that weak arm dangle without support, it can actually injure the patient's shoulder. And it's not always necessary to avoid contact or measuring blood pressure on the affected arm. So there is your answer. That concludes our information on CVA.